Good afternoon and welcome to today's Grand Rounds. Please remember to fill out the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations that I think everybody picked up on the way in. And if you could give the CME committee ideas in regards to future topics and future speakers, we would be appreciative. Today, it's my pleasure to introduce Dr. Denise Sorrentino, who is our speaker. Dr. Sorrentino is a board-certified cardiologist and also board-certified electrophysiologist, and she's here to update us on something that most primary care practitioners see with some frequency. She's going to be discussing the fainting patient. Please join me in welcoming Dr. Sorrentino.
Okay, I got it on. Did I? Yes. Thank you for attending. It's my pleasure to be here. Of course, the fainting patient or syncope is something I see a lot of. A lot of my practice is built around or fostered by a lot of referrals from general medicine, family practice, internal medicine, ER docs, and certainly other cardiologists to evaluate patients with syncope. In this talk, I let Dr. Hallberg know after I made it, really would love to have questions or interaction. I think it's super boring just to look at all my slides because some of them are boring. So a lot of this is, if you have questions, ideas as we go through, please feel free. It is funny to stand down here and have everyone so far away. So I did threaten two of my nurses that I would call on them if they sat down here, so they sat way high too. But certainly I think something like syncope and what do you do in this situation or that situation is really important and interesting. And so please feel free. We're going to be talking about the definition, classification, diagnosis, and treatment. And sorry about the funny lines in this slide, but syncope, the definition is a syndrome. It's not really a diagnosis. It's always caused by something, and our job is to try to determine what could be the underlying problem. But it's a syndrome with a sudden, temporary, self-terminating, usually rapid recovery, loss of consciousness. It's usually always due to inadequate cerebral perfusion due to a factor, and we'll go through all those possibilities, and it's often triggered by a fall in blood pressure. Remember, a fall in blood pressure can be caused by a true drop in systolic blood pressure, an arrhythmia, and or other events that can cause changes in blood pressure. So whenever we see somebody with syncope, we look to see, was it trauma-induced? With a lot of the elderly patients, it's really so hard. They fell, they hit their head. The question is, did they have syncope, fall, and hit their head, or do they fall, hit their head, and lose consciousness due to a cerebral contusion in subdural hematoma or other event? Really difficult, and I'll be going through a little data later looking at, falls in the elderly. Are a lot of falls due to syncope or are they just falling? Non-trauma induced can be syncope with reduced perfusion versus seizure, intoxication, metabolic disorder, and certainly even, I'll just touch on this briefly later in the talk, sleep disorders. We have a lot of people who lose consciousness at certain times of the day or when driving, and the question is, are they falling asleep? Not true loss of consciousness, drop attacks, cataplexy, syncope or pseudo events, less common. Most people who are having episodes where they're falling and losing consciousness are not having pseudo. So I always tell my staff and my referring doctors this, I give everyone the benefit of the doubt. There are some people out there with pseudo events, and I think I see some, and neurology certainly sees some, but most people are having real deal things. Most people do not like falling to the ground or being injured. Usually it's relatively rapid onset, variable warning symptoms, and the underlying mechanism is transient cerebral hypoperfusion. So causes of syncope, this is an important one to know. Common things being common, most things are right over here. Now, that's not everybody. Depending on the age, the background, and the patient's history, which is the most important thing in evaluating a syncopal patient, is history and past medical history. But please remember in this column here, the neurally mediated syncope, vasovagal, carotid sinus hypersensitivity, or situational syncope is in the big 60% group. This is really important to remember. The next big group, which is smaller than the first, is orthostatic. A lot of our patients who are on blood pressure medications, the medications are reducing their ability to respond to positional change, and they have dizziness, lightheadedness, and at times complete syncope. This is the group that we see in the ER or admit from the ER on Sunday mornings at church. So this is either drug-induced autonomic nervous system failure in the Parkinson's patients. Certainly Parkinson's patients are prone to significant orthostatic hypotension. Diabetics often have orthostasis. And again, the secondary are the drug-induced. All of our patients on antihypertensives, if they become ill with a second problem such as a viral illness, a cough, cold, a flu with fevers, they can suddenly become orthostatic. Cardiac arrhythmia, of course, this is my area over on the right side, the less common diagnoses, looking always for bradycardia, true dysrhythmia. So certainly with vasovagal syncope, we can see a pause. We do not recommend pacing those pauses happening during high vagal tone events. But some people truly do have sinus arrests outside of a high vagal tone situation, AV block, and of course the serious or life-threatening, the VT, ventricular tachycardia, supraventricular tachycardia, not necessarily life-threatening, and usually individuals are not syncopal with it. Even my patients who have heart rates of 240 during an SVT, they might be dizzy, they might be lightheaded, especially if they're above the age of 40, but they usually don't have syncope. And then here it states long QT syndrome, but let me say, that is not a complete term. The long QT syndrome is one of now about 27 channelopathies. We're happy to say that as genetics and medicine has continued to advance, the world of EP arrhythmia medicine continues to advance as well, and cardiac arrest, familial dysrhythmias, we clump them under channelopathies. There's long QT syndromes, there's 11 of them now. There's short QT syndromes, there's Brugada syndrome. There's many syndromes of either potassium, sodium, calcium channel abnormalities in the heart that cause arrhythmia. And so it's just not the long QT syndrome anymore. Structural cardiac abnormalities, severe or critical aortic stenosis, hypertrophic myopathy, severe pulmonary hypertension, or aortic dissection. And again, these people can present with a syncopal episode. A good examination and some testing will definitely bring out the cause for those folks. The last two columns are the less common. Those are the more serious. A syncope can mimic intoxication, seizures, sleep disorder, that's somatization, less common, trauma, concussion, low blood sugar, and hyperventilation. So again, seeing these people, I always recommend, if someone has a syncopal episode, so many of my patients will have had one at home or in the restaurant or somewhere at work, and then they refuse to be seen in the hospital, wait to go to their primary care physician 2 days later. I always recommend that if people have an event, it's best to get vitals. Even the most important set of vital signs I have are when the paramedics or EMTs first arrive on the scene. Because sometimes we will see low blood pressure readings there, or even blood sugar readings that are low, that by the time they make it to the ER, already have an IV in, fluids going, they're already better. So as the sooner we can evaluate someone to their event, the more diagnostic our testing can be. 40% of the population has presumed syncope at least once. There is some data to support that. So people in this room, probably almost half of you, have at least had a syncopal episode. It accounts for 1 to 6% of all hospital admissions. We'll talk about who you should admit, who you shouldn't. Most people, again, fall in the first two columns on the left. Most people don't need to be admitted, and you'll be amazed at how much money it costs our healthcare system to admit these people. 1% of emergency department visits, 10% of all falls by the elderly are felt to be due to syncope, and certainly these people have some injuries. So it's a primary diagnosis. This is old data, but this hasn't changed. Syncope hasn't changed much over the years. Primary diagnosis in the ED, 1.13 million in the U.S., and among all diagnoses, including the secondary diagnosis, 1.3 million. So about a third are admitted, 4% for an OBS, and people requiring transfer due to emergency departments' fears that this could be something serious or life-ending. There are some that are transferred as well. So syncope evaluation and treatment, 2.4 billion based on the data from 2006. And an average hospitalization, even though it's brief, it's usually on a telemetry. There are usually more tests ordered, and it's pretty costly. So conservative annual estimates, it comes in higher than our friend COPD. So again, a lot of money spent evaluating that. Most diagnosis for most patients with syncope, evaluation can be done as an outpatient. But again, when you're in the emergency department, the question is, the question for me is too, when people come to see me, and I see lots of people for syncope, 12 years old and above is who I do. So I see a lot of teenagers, preteens, I see lots of athletes, college, high school, a lot of young people. The goal is for me to identify who is going to be the one that really has something serious that I need to do something about to prevent the next episode being the last. Certainly there are, many stories shared by EP docs. When I was in training, one of my mentors would go to, I was at Emory in Atlanta, he would go to a smaller town in North Georgia to do an outreach, and he met their high school quarterback, had what he felt was a typical vasovagal syncope, put him on a little medication, went out to the next high school football game, cardiac arrested, and died on the field. So we always have to be careful to do the best we can to try to sort out who's got something really serious and who doesn't. This is indirect effects of syncope, and we all know this. My last slide has a picture of a semi-truck going down the road. Because once somebody has syncope, currently, recommendations in our state and 33 others is if you've had complete loss of consciousness, should not drive for 6 months. Now again, every patient has their own, I can't not drive, I can't do that, can you write me a letter? But certainly it does affect people if they are restricted from driving, if they are a truck driver, lose employment, and just a lot of anxiety and depression. It's having a syncopal episode is a stressful thing. So to me, I first truly feel a really good history and physical with a past history, because I push people to tell me about past syncopal episodes and family history of syncope, sudden death, including SIDS or sudden infant death syndrome in siblings. I really push them, but the key is asking all the right questions. Initial examination, I always do, and I recommend for everybody, and I think the emergency room here does a great job of it. Everyone needs orthostatic blood pressures, and that includes the 12-year-olds through the 90-year-olds, because you'll be surprised how some people would be volume depleted for one reason or the other and are orthostatic. I think everyone with a syncopal episode deserves an EKG. This includes the 12-year-olds. Again, we see pre-excitation, long QT syndrome. We do find things on an EKG. I put the word possibly in echo. Does everybody who has a single syncopal episode need an echo? Absolutely not. Some people have classic volume depletion, orthostatic syncope. You don't need an echo. Or classic vasovagal, fainted during the blood draw in the lab. You don't need an echo. If they have a murmur on exam, oh, absolutely. A family history of cardiac arrest or hypertrophic myopathy, absolutely, but not just garden variety. As in anything with EP, the presence of structural heart disease increases your risk for serious arrhythmia, increases your risk of having a more serious outcome from your next event, so certainly they need more evaluation. Selected testing, event monitor, Holter monitor, mobile telemetry, and the ILR stands for implantable loop recorder. Over time, we're using more and more implantable loop recorders. They're small. Currently, within the next 12 months, they're going to be available for subcutaneous injection. That will not need to be done with an incision. So the FDA currently has a loop recorder that will be injected sub-Q. In my opinion, probably in my office. It will be a local little injection, and that monitor, we don't know how easy they will be to get out, but we know they'll be easy to put in. But once the FDA approves them, I think a lot of people are going to be having sub-Q monitors. Otherwise, currently it's a small incision. It's usually peristernal. The device is 2 centimeters. It should be a really tiny incision, but it's subcutaneous. We currently do it in the cath lab with like opening a whole pacer tray. So the cost of it is fairly, but it can give us a lot of information. I've got good data to show you on that. Some people certainly do need stress testing, angiogram, EP study, tilt table. And I hate these diagrams, so I'm going to go by it. You know, what you want to do is risk stratify as they come in. If we can make the diagnosis with simple EKG, orthostatics, blood work, they're very anemic, they're very abnormal labs, we stop there. But as you continue to go down with negative testing and or somebody that has structural heart disease, they need further evaluation. The eyewitness is key for me, and I don't know, the neurologists here if they would agree. I always ask if I can to have people come with any new consult I see. I like families. Sometimes they fill the room with chairs and family members. That's great. The more eyewitnesses, if they could describe the way the patient looked, what went on beforehand, what exactly is, and if you read my H&Ps, I usually put all the details there. The eyewitnesses can often make the diagnosis for me. What happened before, during, or after the event, they often make the diagnosis for me. Medication history, of course. Family history, really important. Again, I push my patients on this. Family history of unexpected death. And, sometimes you really do have to push people. And it's a lot of times, their dad did die when he was 42. They never did an autopsy. We don't know. That's important. Through taking family histories, and people don't openly tell you, oh, yeah, someone in my family has cardiac arrest. But I've had patients who haven't completely disclosed, only to find out that they have a family member waiting for a heart transplant for a diagnosis that this patient had that we didn't make until after extensive evaluation, that we find out that her brother died suddenly and her uncle is having a heart transplant for the same diagnosis. So it's really, the family history is really critical. If people can get their hands on the autopsy, and I have had people go and search and bring in autopsy reports, it's really important to me because I need to know those familial disorders. Neurologic history, very important. And again, these are one of those slides that make my eyes glaze. Neurally mediated syncope, very common. An upright, sudden episode of hypotension, bradycardia, and fainting. For some people, it's in a situational event during the vision of blood, during a blood draw, during a poke, during an emotional event, standing upright for a prolonged period of time. I personally do not do a lot of tilt table testing. I used to do a lot of tilt table testing. Right now, often the diagnosis can be made with this careful history and how it occurred or the recurrence of such. Or I'll see many adults who had a syncopal episode, recently saw one, he had the flu, had a syncopal episode, and actually one of my partners was sending him to me for a pacemaker, but when I went through the history, a lot of people, you have to push them. He fainted when he was 8th grade. He fainted in college when he saw blood during a movie in a biology class. He fainted at work in a very hot room. So again, a really good history. Orthostatic syncope, again, a lot of diuretics. I always tell my nurses, one of the best things I do, other than ordering a lot of sleep studies on my arrhythmia patients, is stop diuretics in elderly females. So what happens is we have patients who have been hypertensive for many years, bona fide hypertension, and they've been on either hydrochlorothiazide and then have an ACE inhibitor started and then maybe a third medication, and they've needed it, no doubt. But suddenly now they're 78 or 80. They're actually smaller than they once were, and they're still taking all their meds, but their blood pressure is lower than it once was, and they're having now syncope or pre-syncope. So I'm a big stopper of the diuretic, even though I still know that's the first recommended medication for hypertension. But a lot of people, seniors, just don't need it anymore. Defining structural heart disease, family history, mid-exertional syncope for all the athletes I see, and I see lots and lots of teenage and early adult athletes with syncope. The key feature is mid-exertional syncope. If they're having fainting or near fainting in the midst of exerting, this is serious stuff. These kids can't play until they're fully evaluated. Now, again, I see a lot of kids who aren't having mid-exertional syncope where they're told they can't play, they can't be in PE, but it's that mid-exertional syncope that we're worried most about. Serious arrhythmia, outflow obstruction for hypertrophs, kids that have bicuspid aortic valves no one knew, who are stenotic at high levels of exercise. These are the kids that go down in the football field. And so again, that is key. Anybody fainting in the middle, not after. See, after exertion, it's a little bit more common. So after our patients run on the treadmill, get off, and your blood pressure will drop. So if it's after exertion, that's one thing. But when I see runners or athletes fainting in the middle, serious business. Don't let them play until they're evaluated. So is in-hospital evaluation needed? And this is a question that ER docs have to ask themselves. They too don't want to be the ones sending home the kid or the adult whose next event is their last event, right? So the question is, who needs to come in? Most of them probably can go home. People with structural heart disease who are seriously injured, or those mid-exertional athletes, probably can be brought in, at least under OBS. Many admissions could be avoided by better risk stratification. We went through the initial examination. With the cardiovascular exam, again, I always get EKG. Remember, things like channelopathies, where we have long QT syndrome, short QT syndrome, there's variations of the Brugada syndrome. These are all cardiac ion channel abnormalities. They aren't abnormal on every one of their EKGs. Just like all of you know, Wolff-Parkinson-White does not manifest on every EKG. Depending on vagal tone, conduction down the AV node, a Wolff-Parkinson-White pathway may be very prominent on one EKG and absolutely absent on another. Same thing with long QT, short QTs, and Brugadas. There are ways in the EP lab that I can enhance those occurring, but they may not be present on every EKG. So a normal EKG in somebody who just fainted mid-exertion does not mean it's okay. But it's good to have a normal EKG. We often even will do longer monitoring Holters, where we'll see QT intervals are normal while up and awake, but when they go to sleep at night, the LQT3 is QT prolongation during bradycardia. So when they sleep at night and their heart rate goes lower, suddenly the QTs go way out. So really important stuff. Carotid sinus massage is an underutilized thing, and I always do it. My staff aren't happy that I always do it because I make them bring the EKG in the room, set it up, even in the hospital. Watch telemetry, record constantly. Carotid sinus hypersensitivity, I'll have a slide to show you, but is not uncommon, especially in our adults. Really don't see it in the children or the teenagers. I certainly have diagnosed it in 30 and 40-year-olds, but our senior adults, really important, and I have a good slide for that. The key is to not miss doing it. Because, again, you did the orthostatics, you did the EKG, everything's looking good, but carotid sinus hypersensitivity is a sudden drop in heart rate and blood pressure as well, and is treated mainly by dual chamber pacing. Some of the pacemakers have something called rate drop, where it only kicks in when there's that sudden drop in heart rate. There also is a drop in blood pressure with carotid sinus hypersensitivity, so dual chamber pacing is not the cure, but I'll go through a slide for that. You don't want to press on someone's carotid, and by the way, you don't do bilateral. Don't press on both at once. Do one at a time. We always listen first for a carotid bruit. If you hear a bruit or it's someone with a lot of atherosclerotic disease, it's fine to get an ultrasound first. Again, if they have a 90% carotid stenosis, do not press on their neck. I mean, but that's for real. I mean, so I don't take a chance. If I hear a bruit or I think I do, I'll get an ultrasound before I press on their neck. We don't want to do it on someone who's had a previous stroke or a recent MI. And, so you want to be careful about that. I've got slides coming up on that where I could kind of show you the neck and what we do. But, I have lots of pacemakers in for carotid sinus hypersensitivity. These people often are fainting over and over. They come to the ER, everything's normal. Their EKG's normal. Don't worry, they've had echoes, maybe 3, stress tests, 2 or 3, and no one ever pressed on their neck. So all I do in the office is have them lay head of the bed up probably about 20 or 30 degrees. I take the pillow away. I have them hyperextend their neck, and I do not push very hard. I find the carotid bulb, gently press, and those with true carotid sinus hypersensitivity, you do not press hard, and it's an immediate pause. And usually, the pause continues until I take my fingers away, so we do. But often they will have long pauses, so really important. Who needs, a Holter monitor? Someone has a single syncopal episode. If you take a good history, they don't need a monitor. If they do need a monitor, a longer duration monitor, which is what we call a loop recorder or an external continuous monitor, is a little bit more helpful. They often can have that for a few weeks. An insertable loop recorder can be in for up to 3 years. That small incision, again, they will be injectable, but that can give us data as well for a long period of time. 12-lead EKG gives you 10 seconds of information. A Holter can give you up to 2 days. An event recorder, 7 to the longer mobile telemetry can give you 30 days, but an implanted loop monitor can be there for 3 years. So especially people who have gone for a long time with recurrent episodes, having that subcutaneous monitor placed can be very diagnostic. Here is a loop recorder recordings. The great news is that there's 2 companies that make subcutaneous implanted, only one that will be available in the injectable form soon. But we're able to download. They get monitors at home. They could do the download from there. So if they faint at home, they'll call us. We'll say, did you make a download? We'll pull it up and see sinus rhythm, Brady, pause. And it can be very diagnostic. Very quickly, we can make diagnoses. And I will tell you, some of these patients I put in, they're going between myself and neurology. They're having spells. Neurology thinks they could be seizures, maybe not. Maybe they're even on seizure medication. They come to me, the spells don't sound like seizures, or they're on their Keppra and they're still having spells. And a few of them, fall in that I speak to Dr. Moore or one of the other neurologists, and we both kind of feel they're in that pseudo-syncope, pseudo-seizure group. But, more than once, I will tell you, I've put the subcutaneous monitor in because to me, it's just as diagnostic if it's normal as it is abnormal. I mean, if we could put it in and show the patient, okay, I had a man that would fall down the stairs. You fell down the stairs, but your heart rhythm was completely normal. Well, I will tell you that man that fell down the stairs, I work closely with neurology, and there was a whole lot of issues regarding his disability as well, but we really weren't sure if there was anything going on. I put in the loop monitor. I think it just took him a week to have a spell. He came in. That's before we had remote monitoring. He did have an 8-second pause. So I'm going to tell you, this is, even people that you're just not feeling sure, it's a pretty easy way to make a decision. We could see rapid arrhythmia and VTAC, not only pauses. And again, as neurology will tell you, with global cerebral hypoperfusion, you will have seizure. It doesn't mean you have a seizure focus or epilepsy, but if your brain goes this long without blood flow, often tonic-clonic activity is involved. So that's why, neurology and I see a lot of the same patients. There's been a few trials. We don't have to go through them because this, again, is part of the boring part, looking at putting in loop recorders, EP studies, tilt table test, and making diagnosis. The people who received loop recorder along with the other testing had a diagnosis yield of 43% versus 20% with just conventional testing. So again, probably we wait too long to put in these subcutaneous monitors. It is a surgical procedure. It's zero risk to them. There's nothing that goes into their heart. It's all subcutaneous, but it's getting people in and convinced that they need to have that done. And there's been a few other trials since then. There's been a trial looking at tilt table testing, a negative tilt, a positive tilt, and then EP studies, people with bundle branch block and EP studies. And these are patients with syncope. Again, looking at who's the highest risk group. There were 111 patients, no structural heart disease, tilt table test followed by loop recorder. 82 had tilt negative isolated syncope. Some of these had tilt positive, had some syncopal episodes picked up on their loop recorder that were mainly bradyarrhythmias, probably related to their high vagal tone syndrome. And then the tilt negative syncope had a lot of arrhythmia diagnosed that we otherwise wouldn't have found. Arrhythmia is such an intermittent thing, even during an EP study, which is a test that I do where I put, it's a low risk test, venous access through usually just one femoral vein because it's not an ablation. I put 3 wires into the heart, up into the atrium, at the His bundle, which is marking just distal to the true AV, compact AV node, and then in the right ventricle, I will test sinus node function, AV node function, His function, or distal to the AV node function, ventricular arrhythmias, and I'll do stimulation for all of it. Certainly people can have a normal EP study and have complete heart block 2 weeks later, because conduction system disease is intermittent. It's like the light flickering. You could have pretty good intervals, HV is what we look at for pacing, on one day, and then the next day have high-grade AV block. And so again, the electrical system doesn't go all at once. It's not like an acute coronary occlusion. Arrhythmias are very intermittent, and so having something to look past the EP study if they're normal. A lot of times if I have a syncope patient with heart disease, if the EP study is negative, we put the loop in. I mean, that's the best way for me to say, my test didn't show anything, but there's still things that we could look for. And these are people with heart disease with loop recorder, pre-syncope in this group, true syncope in this group, and things that were found on the further testing, VT, AFib, post-conversion pause, and certainly some people don't end up with arrhythmia. If they have a bundle branch block in a negative EP study, they for sure need further monitoring because a lot of them, again, have that distal conduction disease that's intermittent and will show up as AV block, asystole, and that's important stuff. So conventional EP study is still useful. It's a quick test, low risk, and does give us some answers. And a lot of people, if they haven't had the carotid massage done well, I always, even if I've done it in the office, always on the day of the EP study, I repeat that carotid massage to make sure that we're not missing something like that. Limitations, the yield, if people don't have structural heart disease, is not super high. So even with cardiomyopathies, back in the day preceding primary prevention defibrillators, which that's a long time ago now because now everyone's getting a defibrillator that's primary prevention for low EF, we would take the dilated myopathy, non-ischemic, so normal coronary arteries, EF of 10. Most of the time, those people had an absolutely normal EP study for ventricular arrhythmia. And most of the time, those people within the next 3 to 6 months died of a ventricular arrhythmia. That's what was occurring for so long and prompted the SCUD-HEFT trial, which is sudden cardiac arrest and heart failure patient trial. These were patients without coronary disease. So I'll tell you, without coronary disease, our yield on the EP study goes pretty low. And coronary disease means not active occlusions, but a history of a previous infarct, whether it was a non-ST elevation MI, an ST elevation MI, or bypass surgery. So specific conditions and treatment. Vasovagal syncope, orthostatic, cardiac, we'll go through all of those. Situational syncope, for the most part, again, I usually do not do big interventions for cough syncope other than sending them to someone to get the cough treated. When Dr. Tom Smith was here, this is maybe not all of you remember Dr. Smith, but I had a professor that had, well, it was called a syncope seizure disorder. Of course, he was seeing neurology and me. He was from the vet med school, big guy, and he would repeatedly have syncopal episodes, 2 or 3 a day, associated with seizures. So he was at the hospital and ended up with a pacemaker done by one of my partners. Well, after the pacemaker, he was still having these spells. And finally, he was hospitalized and monitored and watched, and he would begin a very strong coughing event and then have syncope and then hypoperfuse and then seize. The pacemaker doesn't help with that. I mean, that's hypoperfusion related to his extreme cough, but Dr. Smith treated him with inhaled and Flonase nasal spray, and he never had syncope again. Didn't need the pacemaker anyway. Or the seizure medications. I mean, he was on everything. So neurally mediated syncope is a physiologic reflex, cardioinhibitory, which is a drop in the heart rate, vasodepressor, drop in the blood pressure. Some people have more of one than the other, but usually both do occur. Vasodepressor may be masked by the presence of severe bradycardia. So again, the tilt table test does help us make that diagnosis. Treatment. This is not a fatal syncope, but people who have multiple events certainly need to be treated. I always recommend the increase fluid for my non-hypertensive patients, increase dietary salt, regular exercise. They call it tilt training where they're standing, often with support host to increase venous return, and medications. When I go to the EP meetings, at least, the big neurally mediated syncope group that meets, and I always attend one of these because they're so fun. They're much funner than the adult EPs, but it's always a cardiac electrophysiologist at the big hospitals on the East Coast, and they do lots of studies and lots of evaluation. We don't have great treatment for neurally mediated syncope in those young folks who faint a lot, but a lot of meds that can work. Proamotine, which is a vasoconstrictor, midodrine is a generic. Certainly we use Florinef, which is a volume expander. Fludrocortisone works, some of the time and sometimes not. Beta blockers have fallen largely out of use, but not completely. And sometimes serotonin uptake inhibitors will work as well. So if one of my patients is on that, it's not because I'm trying to treat depression, but we're trying to help with their fainting. Rarely, these kids do, and when I use the word kids, I'll say teenagers. Very rarely in my practice, like maybe 2 in the 18 years that I've been here, end up with a pacemaker. And those are just intractable syncope with pauses despite all medications. Those are rare, and maybe only one did I put in. So carotid sinus syndrome, again, this is the one that's often missed. It's not super common, but is really easy to evaluate. 50-point drop in systolic blood pressure, and it's greater than a 3-second pause. If you press hard enough on anyone's carotid, they will slow down. That's normal. It's getting the big pause. So what happens, or what's the proposed mechanism? The nerve endings in the carotid sinus respond to deformation or pressure, increase afferent signals to the brain stem, and then the reflex increase in vagal activity, diminution of sympathetic tone, which results in bradycardia and vasodilation. So pacing and carotid sinus hypersensitivity, syncope recurrence, no pacing, half recur pacing. Still, they're getting the drop in blood pressure. So for some of my patients that I pace, I'll say, you may go from a blackout to a grayout. It may not be a complete, but most of them, for the most part, have significant improvement. So this is syncope and falls, another study in the elderly pacing and carotid sinus evaluation. And so this looked at greater than 50-year-old adults with non-accidental falls, pacing versus no pacing. The paced had 70% reduction in their falls, syncopal episodes reduce, injuries reduce, strong association between non-accidental falls and carotid sinus hypersensitivity. So this should be considered in all adults over 50. I definitely start carotid sinus massage in adults over 35 who have unexplained syncope. Orthostatic, we kind of went over this as well. Certainly some of the diseases that the neurologists treat, multi-systems atrophy, Parkinson's, diabetics certainly can have orthostasis. Easy thing to check. I do lying, sitting, standing, 2 minutes apart, heart rate and blood pressure. I know in neurology some do longer periods of time in between. It doesn't matter. You want to get 3 positions. Treatment, if you can get them off meds or on more fluids, that helps. Not everybody can have salt. So we certainly don't want to take our 90-year-old, they're hypertensive when they're flat, very hypotensive when they're up. We don't want to have them eat a lot of salt and bring their 177 systolic to 197. Sleeping with the head of the bed elevated is helpful. Tilt training again. Support hose, I prescribe them all the time. Not everyone wears them. I used to be a much meaner person and order the thigh highs all the time. 20 to 30 millimeters of mercury, thigh high. Really, the seniors cannot get these on. They even have that little white device they can get to help pull them on. It just doesn't happen. So as time has gone on, I just recommend knee highs because I'm being realistic with what can these people really get on. Sometimes it's like a family event with family members coming and trying to get their support hose on. So I try to use what really they can do. I'm a little less mean than I was a few years ago. So medications, the problems with orthostatic hypotension, especially in our seniors, they can't take these meds. Again, they're already hypertensive. I'm trying to stop their antihypertensives, which are vasodilators, which are part of the problem. So giving volume expanders like Florinef or vasoconstrictors like midodrine are difficult. Certainly if they're very anemic or renal failure, giving them a volume expander that helps with their hemoglobin like erythropoietin is great. And certainly some trials have even looked at non-anemics getting EPO. That hasn't been clearly shown to be help, so it's not used regularly. So cardiac syncope, arrhythmias, structural heart disease, these are the life-threatening ones. Syncope during exertion, again, the serious ones. Looking closely at the EKG for marked bradyarrhythmia. Sometimes, again, if they'll come to the ER right when the event happened, and again, paramedics will tell you a lot of these people decline. They end up waking up, regaining consciousness, and refuse the ride. So, there's no one at fault here. People feel like, I'm fine, I'm embarrassed, don't bring me in, I'm fine, and so they don't. But you'll be amazed if they come quickly. First of all, paramedics can often pick up bradyarrhythmias or hypotension. And people with serious ventricular arrhythmias often will have some runs once they reach the ER as well. So I really like to get as much monitoring as I can on them. Acute MI, of course, we should be able to recognize that, treat that, and intervene. Usually if an acute MI patient had syncope, it's either due to serious arrhythmia or AV block, which may go along with right coronary occlusions. There are some important diagnoses that, again, for me, is at the top of my head. Every day I go to the office to see consults. We can't miss hypertrophic myopathy, arrhythmogenic right ventricular dysplasia, which is now called arrhythmogenic right ventricular cardiomyopathy, which is going to likely be renamed again in the very near future as just a channelopathy cardiomyopathy, because now we see it's involving the left ventricle, sometimes even the atria. Very important stuff to see. High risk of sudden death, felt to be the second most common abnormality cardiac-wise in all athletes who have sudden cardiac arrest. Aortic stenosis. Oh, I might have gone the wrong way. PE, again, some of these presentations are pretty serious. An aortic dissection, usually by the time they arrive, they're hypotensive and having problems. But these are the serious ones. I mean, these are the ones we don't want to leave our office or go to the ER and be sent home. These are the admissions for further evaluation. AFib and aflutter with rapid ventricular response, again, usually can lead to lightheadedness, but in the elderly who are on a lot of blood pressuring lower medications can also lead to syncope. Torsade also can be important, very serious stuff. So again, looking at the EKG, here we have an 83-year-old with syncope, was on telemetry, wore a monitor, had a pause. And again, an intermittent. If you were to look here, you'd see a bundle branch block, but really nothing abnormal, and there we see our pause. Here's a 28-year-old, multiple syncope, has a monitor, and it's a ventricular tachycardia. So long QT syndrome, again, there's multiple forms of the long QT syndrome. Some of them occur more commonly during certain activities, including one LQT is mainly while swimming. Versus sleeping, versus exertional activity. There, long QT is not one diagnosis, it's many. But it's torsade or polymorphic VT that we're worried about. Some can be drug-induced. As you know now, even prescribing meds here in the hospital, there are multiple drugs that can prolong QT, and certainly you get alerts if you're prescribing a Levaquin on somebody who is already on another QT prolonger. Concealed forms that can be unmasked by drugs. Even for me, during a device implant this morning, one of the assistants asked me about the Brugada syndrome. We know Brugada syndrome is not a long QT, but it's a sodium channelopathy that the EKG can appear pretty normal, and then we have in the EP lab infusion of a sodium blocker, and they have a classic Brugada. Here is torsade. So what it is this is occurring during bradycardia. The QT interval is hard to say, it's long here because we only have one beat, but it's polymorphic VT. So you think, well, torsade, geez, if they have that, then they've had an arrest. And we're not, syncope, we're not talking about cardiac arrest. We're talking about people who regain consciousness. But interestingly enough, a lot of long QTs will have syncope and revert back to normal on their own without requiring a defibrillation. So I don't know if that's a sign I need to stop. It went out. Okay, I'll be quicker. Yep, I almost need to stop. Pacing, bradycardia, indications for pacing. Syncope and bradycardia, the pauses usually need to be greater than 2.5 seconds. Yes, we pace them for that. Here are all different forms of arrhythmia. EP studies and ablations are recommended for those who have syncope or pre-syncope and a documented arrhythmia, or classic symptoms of an arrhythmia, like right before I fainted, my heart was racing out of my chest, beating out of my chest. We do EP studies if we can find. It must be the battery. If we can find something to ablate, we do an ablation. And here's the picture. You know, this is it. So many patients who have syncope need to drive or want to drive, and you know, it's our responsibility. You know, so I always tell patients this: I didn't write the law, so they all get mad at me, but I didn't write it, and I'm not the one that can repeal it either. But what the law states is if you've had a syncopal episode, you should not drive a motor vehicle for 6 months. And I'm sorry about that, but that's what it is. Now, you know, that includes, even if I put a pacemaker in, remember I just told you, carotid sinus hypersensitivity is one of the reasons I put pacers in, but you could still faint with a pacer in. I mean, a lot of times we make our best diagnosis, but that doesn't guarantee they won't faint again. It's like giving someone seizure medications. They're choosing the best meds they can for that patient, but you're not going to guarantee they won't seize again. So 6 months is the law. I don't call the Department of Transportation, but I always clearly tell the patient and document it. And it's often hard because what happens is they've seen the ER doc and they really weren't told. And so they've been driving. And then they've seen their primary doc and no one told them about not driving, so they're still driving. And then they come see me and I tell them, you really shouldn't be driving. And there's just this huge anger thing. So, you know, we're really concerned about, especially our commercial driver's license, our CDLs that are out there with syncopal episodes. Of course, it's just a disastrous. And I was driving home from Des Moines late in the day. I don't know exactly what happened on 13th Street, but you know, there was that horrible motor vehicle accident where someone died on 13th Street, which is right about very close to our office. And all I feared was that was one of our patients that drove out, had syncope and drove across that and hit the side of that bridge and hit the other car. But I'll tell you, there's a lot of people out there that I tell them they shouldn't drive. They take their keys, go into their car, and drive away. So I think it's important to tell people, though, it's our responsibility to let them know what the law is, and not everyone follows the law. But all syncope, even if I put a defibrillator, even if we find out they have VT and I put a defibrillator in, for my patients, the 6-month law holds. Again, I don't want to have someone back driving prematurely and have real problems. I don't know what neurology does. You know, I don't know if you guys hold that firm, but we have all the data written up, and if a motor vehicle accident was involved with that syncopal episode, certainly the DOT is really involved with removing the license, then making me fill out papers yearly for many years saying that they're safe to drive. I've had people that, you know, have run over stop signs or whatever with it, so their driver's license are removed. Then I'll do an SVT ablation, and they'll continue to come back to me yearly for papers to say it's okay that she drives now. But for the most part, I think our job in the state of Iowa is to give people the law, including in the emergency room, and then support it along the way. And again, I don't know if neurology chooses a different course for their patients who they're treating for seizures, but at least for cardiac syncope, because a pacemaker or a defibrillator doesn't guarantee you'll never collapse again, or an ablation. And I'm treating my best bet on diagnosis there, so that's how I do it. Any questions, please? Yes? No, I mean, the law will say loss of consciousness or syncope, or, you know, I do have the whole law printed up in a drawer by my desk. I mean, you know, because we want to do the right thing, you know, it's all there. But so, you know, that's again part of my interrogation. You know, did you pass out? You know, well, not completely. Well, you know, and then again, I go for those witnesses. And the wife will say, no, he did not. He sat against the wall. He didn't look good. He talked to me the whole time. And that's why my notes are long. I try to document that, just the truth, you know. And if it was he slumped on the floor, then it's going to be there. But of course, the pre-syncopal patients, it's not like I tell them go drive the truck. I never do. But at least there, once we've made a diagnosis and treated it, I'll say, you know what? We've made the diagnosis of intermittent AV block, your pacer's in, you never did faint completely, and so this should be fine. Yes. 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 Yeah, as you saw in one of my slides, like the incidence of long QT syndrome is extremely low. Even though they're still identifying more different types of LQT, these are rare, true long QT syndrome. Now, any of us in this room, if we're given enough QT prolongers, specifically an antiarrhythmic, the people I worry most about, or not, I don't really worry about them, but the people I listen to the pharmacists when they send me the order or send me the disclaimer I have to check through, I've reviewed this, or benefit exceeds the risks, are the people on antiarrhythmics and you're adding a QT prolonger. I'm promising you our antiarrhythmics do prolong the QT, not because you have a syndrome, but because that's part of the way they inactivate the arrhythmia circuits. So I'm promising you that our class 1, class 2, class 3 agents are prolonging your patient's QTs. And for a lot of these patients, they need that drug for their AFib or VTAC or both, or, heaven knows all the arrhythmias some of your patients have. So those are the folks I really like to say, please don't stop their Sotalol or their flecainide. Please instead choose an antibiotic instead of Levaquin. Or, instead of something else that's going to prolong the QT. So that's the time I'm concerned. Now, again, if you have a patient who has a long QT syndrome, I stay away from all drugs because some of my patients only manifest their LQT when they're challenged. One of our patients is a very nice young lady, dance teacher from a neighboring town, who only manifests, and boy, did she have a long QT. I mean, it was at least 640 in the outlying hospital when they gave her an antibiotic plus a second antibiotic that could prolong QT. She never had syncope, but she truly had very, very long QT. So she's somebody, I send them home with a list. There's an online spot that you can get a list of drugs that may, will, or do prolong the QT interval. And for her, I just asked her to be on none of those drugs. We didn't pace her, we didn't beta block her, and didn't put a defibrillator in. She had no syncope. So I think the most serious thing is taking an antiarrhythmic that we know prolongs the QT and adding drugs on top of it. And I prefer not to. Pharmacy will call me, I'll say, no, take that off the list then. And that's where we get in trouble with, you guys are the hospitalists when we say, they're susceptible to Levaquin. Well, we don't want you to use that. Sometimes I've even held off on starting antiarrhythmics if I have someone with an infection or some of the antifungals prolong QT, that they need to get that treated first before I can safely use my drug. More questions? The long QT story is really funny, though. The FDA just went nuts on it. As everyone knows here, years ago there were some pretty good GI medications that could prolong the QT, and as you know, this is going way back for me, but one of the antihistamines, I'll forget the name of it, because that was way back, I think I was just an intern, could prolong the QT and cause sudden death. It was such a huge deal for the drug companies and the FDA. Every drug released in the United States, and I don't care if I'm talking non-cardiac drugs, if it's for diabetes, if it's for the skin, if it's for chemo, every drug in the U.S. now has to go through QT evaluation, every single drug. And it's sad because it's held a lot of drugs back from release because you have to do QT testing on every FDA-approved drug because of the bad things that happened with an antihistamine, and that was an over-the-counter antihistamine from years ago, and another GI medication that was great for, I think, dysmotility. It really worked well, but it was pulled from the market due to its rare occurrence of prolonging QTs and people probably with the underlying long QT syndrome. So I'll tell you, all the drugs waiting to be released, they have to have so many evaluations on animals and humans for long QT. So probably they went overboard on the QT thing. It's so rare, but no one wants to have a disastrous antihistamine-caused VF arrest. Any more questions? Thank you.